Hi, my name is Micah Long. I'm an anesthesia intensivist and former pediatrician, and I'm going to tackle a really tough topic today, which is airway experience and patient outcomes. I say it's a tough topic because people get very touchy about clinical skill in emergency intubations. I happen to be a regular educator of non-anesthesia trainees in doing airways, and I think it is perfectly wonderful, and I love that role, and I take it very seriously. And just like anything you do infrequently, you should recognize your limitations and the risk you bring to the patient in order to do it safely, and you should play to your strengths accordingly. But most of the literature in airway studies shows that decreased experience is associated with worsened patient outcomes. I think it's remiss to not talk about it. One of the reasons this discussion is so important is that many training programs don't adequately prepare our EM or critical care in non-anesthesia based fields adequately for actual real-life intubation in high-risk situations. This study on the left is a study looking at the learning curve for intubation for EM, which oddly enough is actually faster than the learning curve in other fields. I think there's something to be said for the pressure of knowing you've got to get it and you may not have 500 times to practice and learn. But their speedy learning curve is interesting because I put the error bars here. Very, very few folks are really doing over 120 airways. The median is well under 100. And again, first pass success is reflected in this lack of experience, right? This is lower than what it is in other fields and with higher experience rates. Now, of course, their airways are complicated, but some of this is straight up volume of experience. Similarly, in critical care training, very frequently our fellows are not being adequately trained in really any airway technique. Right, look at these median or estimated number of experiences, 0 to 10 in over half the programs. Some places that do it a lot, of course, get more experience, but nobody's crossing 100 there. And what I found really remarkable about this is that LMA placement for pulm crit is very low. And the reason that's really important is that if you're not going to do many VLs, then you better really be good at bag masking and at LMA placement. And for our pulmonology colleagues who can run circles around everybody else with a bronchoscope, an LMA to bronchoscope rescue seems to be a really wise way to save a bad situation, but even that has not been done. Here's a major registry study that looked at a national emergency medicine group, just looking at how many people intubate, how many docs intubate, intubations per year, per training. And again, we have a lot of people who not only don't get trained in their training, but who are minimally trained afterwards. And so as faculty, you're not even getting practice or ongoing maintenance of skill. Now, this experience and training matters, and it matters because the experience or lack of experience you bring to the table impacts your patients. The Makocha score was an effort led by Audrey de Jong and Samir Jaber and the French group that does and looks at thousands of intubations. And their Makocha score looked at the incidence of difficult intubation. And they came up with this score as a calculator for difficult intubation. And you notice the last one is non-anesthesiologists. And this matters because the Makocha score is associated with difficult intubation, but if you had a difficult intubation, you were more likely to have mortality and negative outcomes. Similarly, the Washington group out at University of Washington, led by Dr. Aaron Jaffe, did a study looking at their pulmonary fellows and how the lowest saturation was impacted by experience level. And this is a group led by an anesthesia intensivist that did medicine, that is practicing in the MICU, and who showed that, and who does an immense amount of education around airways. So this isn't, out in wild cowboy land where you just do what you want. This is in a very well set up training environment. Of course, and it's really important to say this has nothing to do with the field you train in. This has to do with how often you practice, how much preparation you bring into that practice, and how you approach the situation. It's more important that you are ready, prepared, have run through everything cognitively, that you are absolutely fluent in every algorithm for backup intubation, that you have the leadership skill and medical knowledge to manage decompensation, and that you have the maturity and leadership skill to manage under pressure, which not everybody has no matter what field they're in. Doesn't matter what field you come from, you can become a phenomenal airway expert, but it's a lot harder to do that without a lot of airway experience and really focused effort. It, of course, can be done. It can be done really well, but it takes very focused and directed effort. When I'm asked that or asked to comment on how much effort, how much experience does it take, it's a hard question to answer. But what I look at is some of the studies looking at anesthesia residencies. So this is a really well done study in the Midwest, one of the flyover states, that looked at anesthesia residents and their first pass success over time during their training. Really well matched, well studied. And what I notice is very obvious here is that you get major improvements in first pass success year to year. And you have to imagine, an average OR day, you're going to intubate between 1 and 3 people. And over your course in training, you're going to have a whole bunch of emergency intubations and awake intubations and hard ones. And so for my training program, for example, we were graduating with somewhere between 1,000 and 1,250 intubations. I'm not sure for this program, they don't publish the number, but you have to assume hundreds of intubations with this ongoing improvement in first pass success, some of which is not technical and probably evolving as leaders and as physicians, but some of it's technical ability. JAMA Open just this year looked at adverse events by EM resident year, and they had overall low first pass success, but they had fewer adverse events as you progressed in training. Another study shown on the right, same thing for mortality, and this is for EMS clinicians or providers, whatever you'd like to call them, where the cumulative experience in intubation was associated with mortality when they had to intubate people in the field. And major airway studies like Makocha that I mentioned and the Intube trial all are consistent with this phenomenon. Intube is a JAMA publication, came out not long ago, looking at over just about 3,000 patients, 197 different hospitals over 5 continents, and it was really a descriptive trial, just looking at intubation practices and what happened. And what I was astonished by were that residents were intubating, half the patients, and only half the patients were intubated by anesthesia, either trainees or faculty. Major adverse events occurred frequently, which we know, right? We know this is a risky event, and these events correlated to mortality, and these also correlated to first pass success. So if you get it the first time, if you're fast with your intubation, you had less bad things happen. That makes sense. But also speed with the first take was better, right? So success, getting it right the first time, occurred more often for faculty intubators, anesthesia physicians, as well as with use of VL. So while I readily train non-anesthesiologists in airway management, part of that training is learning what you can and can't do and what risks you bring to the table, and then what strengths you bring to the table so you can manipulate and adjust what you bring to the table to optimize how your patient does. On the left are expert studies looking at complication rates. On the right are studies that are mostly Palm Fellows, just out of ease of the US model for studies and intubation practices. And while we look at anything published as, of course this must be safe, this is published airway literature, they're not. These are different things. When we look at experts to non-experts, the rate of adverse events are simply different. All right, I want to say this again. This is such a tough topic, and I have always hesitated to harp on it because I really value my EM physician colleagues. I think they bring so much to the table, but there's a lot to be said for experience. Now, skill, technical skill, and just experience doesn't mean you're good, right? And there are really excellent airway experts that get there rapidly, and there are people who've done lots of airways who struggle, and that can be due to not doing the work required to learn the algorithms and work through them. It could be due to anxiety under pressure or learning how to lead under fire, so to speak. Could be that you haven't had the volume of cognitive strain of a really hard intubation ICU. So a lot goes into this. I do think, however, though, that some airways are best for the most experienced person in the room, and it doesn't mean that every airway needs to go to the experienced one, because you're going to have a generational loss in skill in the airway. There's very few airways that you can't supervise and rescue, but there are some you have to be careful with. And again, training and experience is more important than who does it. You don't have to run around stealing airways as an anesthesia doc, but there are some times that you should be ready and nearby and right at the bedside. I've really limited this to 3 airway types, and each of them has an amount of discretion built in. One is when you can't tap the airway more than once without causing swelling and edema. That's when first pass success is crucial. Swollen airways. Inspiratory stridor, failed extubations. I supervise those, it's okay, but I watch as they go and I'm ready to take over instead of tapping at the airway for multiple attempts. Mandated speed, messy airway with active aspiration, an active hemorrhage bleed where the airway is going to get completely occluded and you're going to lose the ability to tube it soon. And finally, this is the biggest gray zone one, but when you have to have undivided attention, one person has to be airway focused and one person has to be hemodynamic focused. When I have that situation, if I have a learner where I might have to back them up for the airway, we really have to talk about what our hemodynamic management will be before I take over the airway, because they might have to take over hemodynamics. And if it's really high risk, like an impending arrest, maybe that's the wrong time where a switcheroo could really result in some real problems. That's things like, an impending arrest, pulmonary embolism that you're also lysing, horrible LV failure, active MI, and you're trying to get to the cath lab. Those sorts of things are where I look at airways and think, this needs to be somebody who can get it right and get it fast.